and I'll leave it up to you now. Is that all right?
Yeah, definitely.
Great. Thank you, Ian.
Yeah, thank you, Vaz. And thank you, everybody, for joining us tonight. Yeah, my name's Ian MacDonald Nethercott. I am one of the emergency consultants in Addenbrooke's, along with Vaz. And thank you to him for getting this teaching in the evening started again. So this is hopefully the first of a weekly teaching that we'll be providing going forwards for any and all students who want to join. I think we're very keen for feedback, especially as we're just getting it going. So you've all received an email from Shan inviting you to this talk. Please do give her some feedback at the end of this, good, bad, whatever you think. You know, we're emergency physicians, we're pretty thick-skinned people. We get a lot of criticism face-to-face. We can handle a few emails. If you think things could be improved, things that you didn't like, then please do tell us. But also things that you did like, do let us know, because we can try and do more of that. And any particular topics that you'd like to hear from. The beauty of emergency medicine is, of course, that we're generalists, not specialists, but we do touch on every specialty. And so whatever gaps you may find in your training, you may find that that's teaching that we can actually provide. So anything that you would like to know more about, please let us know. Okay, one thing, I can see that again, Katie Law is not able to join us. Vaz, any suggestions?
Sorry, what did you say? I just missed that because I was trying to get someone in.
Would that be Katie? Because I can see she's trying again. It's not working.
I think she's back in, I thought.
Okay, excellent.
She is in. What's the question you asked me, Ian?
I can see that there's problems with Katie Law getting in. That was the question.
Yeah, it's sorted. I think
Lovely.
she's in.
Okay.
On this thing.
We're there. Okay, fantastic. So this talk is about silver trauma. Now, the first thing, and I think the most important thing to emphasize, is that trauma as a discipline isn't really core medical school training. You know, as you go around orthopedics and general surgery, yes, you get the management of injuries as part of those specialties, but you know, the primary survey and management of trauma in the emergency department is not considered core training. So if I end up talking about the primary survey as the way to examine your trauma patient, that's not core knowledge and not something you need to worry about knowing for your finals. So far, I'm working on this. I'm trying to get it in there, but so far it's not. So just to be aware of that, okay. But that doesn't mean it's not enormously relevant to you. And the reason I picked this topic is because when I was in an FY1, I found myself managing silver trauma without really any specific training. And the reason is our wards are full of elderly patients. And elderly patients can fall over. And as I'll show you in a minute, that can be major trauma to somebody who's frail. And if that patient were to fall in the community and show any kind of signs of illness, and those signs might be very subtle, they'd be picked up by paramedics and pre-alerted and met by a team of consultants and registrars in the emergency department who've got a pretty good experience of assessing these patients. But if it happens on the ward at 1:30 in the morning, that will be you by yourself. And I think it's important that you know what the potential pitfalls are and have some basic idea of the framework for assessing trauma patients so that you don't risk missing really potentially serious injuries on the ward. So that's the idea for the talk. Now, before I go any further, I have to say it's one of my faults. I'm not great at monitoring chat. So I'm just going to appoint Connor, if you're there, simply because in my screen, you're the first name under me. I'm going to ask you to monitor the chat. And if anybody puts up a question in chat or anything, please, could you flag it up if you think that I've not picked it up after a minute or two? Is that all right?
Yeah, no worries.
Thank you. Okay, so moving on. If I can get my screen to move on. There we go. Oops. Yeah, okay, so this was pretty much a case that I did manage, and he was all right, but it's the kind of problem you might get presented with. So I was an FY1 in neurology, my first job up in Edinburgh, at Western General Hospital, and at about 2 in the morning, I got a bleep from a nurse to say, we've got this old gentleman who's fallen over. We didn't see it, we just heard a thump. We've put him back to bed. His obs are normal. And now you have to come check him over. And then she hung up the phone pretty much before I could get a word in edgeways. So I kind of thought, that sounds tricky. But looking at it now, thinking about it now, what would you, as a you know, if you were in my shoes, what would you be concerned about? And do you think that this patient is a priority? Now, we all go around with lists of patients we urgently have to see: the patient with chest pain, patient with breathlessness, patient in pain, the patient with low blood pressure. In general, is this patient a priority?
Someone's just saying in the chat, and it's the case for me as well, that the slide hasn't moved on.
Oh, really? So are you still seeing?
So we're still on the title slide.
Okay. If I move it on again, are you still on the title slide?
Yeah.
Oh, right. Okay, thanks. Let me hold on a sec. Let me see if I can fix this. Can you see vignette now?
No.
Ian, I think you're not on what you call, you know, like presentation mode. It looks like you got. It looks like your web browser.
Yeah. So I had this in Google Slides, and it worked for me like this earlier.
Do you want to go off and come? I mean, not go off. I mean, just redo it.
Let me just restart it again. Give it once before I go off. Now, so you see silver trauma on a ward near you, yeah? Now, if I move it on, do you see vignettes now?
Still no.
Still no.
No.
Okay, right. Let me see what I can do then. I'll download it and open it in PowerPoint and see if that improves things. Apologies, folks.
I think while Ian is doing that, I was just thinking the problem with silver traumas, it's not a problem. I mean, you need to have a high, very high you have to have a low threshold of suspecting injuries because the physiological reserve is pretty poor. They've got multiple comorbidities and they've got medications and so on. So I think, like Ian said, we are learning as well as we go along, even though we are a major trauma center, that how to manage them. Because a simple fall may cause a lot of issues.
Okay.
There you go. Yep.
So I'm up again. Let's see from beginning. And if I advance it, do you see it moving now?
Yeah.
Excellent. Okay, so I've gone through the vignette. So you all got a little chance to think there. So what concerns might you have, and do you think this patient's a priority?
I think the first thing that concerns me about that is that it was unwitnessed. Second thing is their age as well. So just off the cuff, if you're thinking about if they've hit the head, for example, then someone that age might be at risk of subdural hematomas. So that's, you wouldn't assume that, but you'd have that at the back of your mind that that could be a possibility in terms of what could be going on.
Absolutely. You're absolutely right. So because it wasn't seen, he could have had so trauma falling from standing is really serious, and I'll show you that in a second, in the elderly frail patient, and age does kind of go along with frailty, doesn't it, more or less. So he's frail. Yes, he's at risk of major trauma from a fall from standing. So and we don't know, could he have hit furniture on the way down that would exacerbate that? But that is, of course, moving on straight away to the consequences of the fall. Anything about the causes of the fall? well, why was this gentleman getting out of bed in the morning? Now, it could be a bit of a delirium. It could be that he needs to go to the loo every day, but maybe he was going to the nurse to tell them about some terrible chest pain, or he was suddenly very confused and disorientated. There are really time-critical illnesses that could be affecting his judgment and that prompted him to get out of bed, and that we shouldn't miss those in our search for injuries. So it's perfectly possible he's having a STEMI or a stroke or something like that. Okay. And in terms of priority, and this is what Baz really kind of nailed it on the head there. The elderly are extremely good at hiding the severity of their illness in all sorts of ways, and that is absolutely true about trauma as well. So OBS normal does not mean a well patient in the elderly, and so you just don't know. He could be absolutely uninjured, but he could be hiding some really life-threatening injuries, not showing any signs yet. So yes, he's a priority. Is he the top of your list? Well, if you get a call at the same time asking you to see somebody who's genuinely a STEMI, or somebody who's crushingly hypoxic, having been given too much fluid, that becomes a judgment call. He is perfusing. So maybe if you've got an obvious evidence of a time-critical illness somewhere else in the hospital, you might have to go to that first. But this guy needs a very early review. So here he is again. This is Jim, not actually Jim, it's a Shutterstock image. But and this was the patient that I went to see. So he had a TERP, and he was a completely cognitively intact, independent gentleman who had developed a mild delirium following a routine TERP. And he was on the ward as a delayed discharge getting some antibiotics. Course uncertain, I didn't really know about that. His past medical history: AF, hypertension, previous TIA. And the nurses said they'd moved him to this side room because he'd been doing a bit of nighttime wandering, but seemed normal during the day. And they'd heard a thump and went in to find him on the floor beside his bed. He was communicating with them, so they just lifted him into the bed. Then they did some OBS, and that was normal. Now, in the history, are there any markers there in his past medical history? Are there any markers that you can think of for particular risks or things that might make it difficult to assess this patient?
He's already got delirium. Oh, sorry.
So there was a female voice. If you could go first.
So I don't know if this would make it more difficult to assess, but with the atrial fibrillation, he's likely to be on anticoagulation. So if he had an injury due to the fall. Correct.
At risk, heightened risk of bleeding because he's anticoagulated. Absolutely right. And along those lines, in medication for AF, is there anything else that might make him difficult to assess? So he most likely is going to be on a beta blocker or some other rate controlling agent, which means that even if he is becoming hypotensive and his body wants to mount a tachycardia, the beta blocker will absolutely prevent that. So that hides potentially the signs of serious hemorrhage. Likewise, he's hypertensive. And we don't really know what the blood pressure is of hypertensive patients in the middle of the night once their antihypertensives have worn off. So if OBS are normal, if his blood pressure is normal, well, that might be relatively hypotensive to him. If he normally would have a systolic of 180, and now he's got a systolic of 120, that would be kind of hidden, but a missed marker for serious blood loss. Yeah. Okay, and then there was a male voice. Did you have anything else to add?
I was just going to say, like, because he's got delirium and you don't know what his baseline is. You don't know if he's like got worse because of what's happened, if he's hit his head or anything like that. You don't know if that's made it.
Yeah, exactly. Just like drunk people might dismiss the signs of serious head injury as, oh, that's just his delirium. That's how he is. So yes, so that crops up as a cognitive bias, doesn't it? Okay, so good. So we're aware as we will go up to him, one, that there's potentially time-critical illnesses that caused the fall, and B, this normal odds might not mean very much at all. Okay, so how I'm going to organize this talk then is we're going to look at a bit of an overview of the problem of trauma in the frail, some specific patterns of injury to look out for. Now, there's no way in the world that we can cover all of trauma in one session. So we're going to focus particularly on the common injuries that occur in the elderly. And then if there's time and people are still willing at the end, we'll look at some specific skills, like how does a primary survey look different to the sort of the HCE assessment of a sick medical patient? How do you clear a C-spine or a thoracic or lumbar spine? And how do you get somebody off the floor if they're in pain? Okay, does that sound good? So when we look at the problem, we've got great data from a national database called TARN, which is Trauma something research network. I can't remember what the A stands for. And it collects data on all patients who meet criteria for trauma of a specific severity or above, and who are admitted to hospital for a few days. So it captures all these patients that are really seriously injured and tries to exclude the ones that were only suffered minor injuries or weren't life-threatening in any way. And they found that 60-year-old and above patients account for more than 50% of those severely injured patients being admitted to hospitals. And that's excluding common injuries like neck of femur fractures or Colles fractures. When we go through them, all these charts are stratified by age. And I think it's important to remember that age doesn't correlate brilliantly to frailty, but it does pretty well. Frailty is almost certainly a better, oh, thanks, Vas. Frailty is certainly a better predictor of serious injury, mortality and morbidity than age per se, but it's a reasonable correlation, and it's how TARN decided to do it. But I would like to remind people that that age doesn't mean everything. So I spent a year working with a guy who was 75, and he was stronger than anybody else in the team. This was outside the hospital. We were doing these kind of convoys of heavy vehicles, and we were sort of sleeping in the cabins that we towed as we went. And they were pretty comfortable cabins for all of us, but this guy decided he preferred instead to sleep in a sleeping bag on the top shelf of a trailer that was actually just full of kit in 0 degrees centigrade. He was tough as an ox. He could lift anything more heavier stuff than any of the rest of us on the team. And he was 75. But by contrast, my grandfather at 75 was so frail he couldn't take more than 10 steps because of rheumatoid arthritis. So frailty is the best thing, but age is what we've got in these slides. So the point is, it's worth, when you evaluate your patient, documenting what you think the frailty index of your individual patient is. Okay, so looking at what kind of causes of trauma do elderly patients suffer. Now, these bars represent age bands, and excluding the one on the left, which is quote unquote young people, the ones on the right are all sort of split by decades. And then the coloured sections gives us an idea of what caused their trauma. And as you can see, between 16 and 60 odd, it's slightly less than 20% are admitted to hospital because of injuries caused by a fall from less than 2 meters. In other words, a fall from standing, or a fall off a low ladder, or a fall out of bed, or fall out of a chair. But in the 90 plus category, it is well above 80%. And it's around 80% for the 80 to 89% category. And then a fall over 2 meters accounts for a fair bit of the very elderly as well. Now, how on earth are the very elderly managing to fall more than 2 meters? Can anybody think?
Stairs.
Yes, exactly. Fall downstairs. When I was a student, I was taught every day in the emergency department, somebody comes in at 4 a.m. with heart failure. Well, I think that cohort has vanished. They're managed very well with cardiology. But what they've been replaced by is patients who present at 4 a.m. who've fallen down a full flight of stairs. And that's presumably because of their diarrhea. I don't know, they're getting out of bed to go to the toilet at 4 a.m. and they're toppling down the stairs. It's every night in recess, there'll be one. Now, so that's the mechanism, but let's look at deaths by mechanism, and you see it's exactly the same pattern, except it's less in the young, less than 10%, but it's more or less the same percentages in the very elderly, that a fall from less than 2 meters causes the vast majority of deaths by trauma in the very elderly. And a fall of more than 2 meters accounts for most of the rest. And whereas in the young, outdoors, dark green, accounts for predominantly the majority of trauma. In the elderly, it's mostly indoors, at home. Do we recognize major trauma in the elderly? Well, not very well, and that applies to 999 call handlers. It applies to the assessing paramedics. It includes the triage nurses in the emergency department, and it includes the emergency doctors looking after patients. We all miss major trauma in the elderly. So if you look at the proportions that are of major trauma that was admitted to hospital when it was entered into the TARN database, but look at what proportion was identified as triage positive, pre-alerted, and was received by a trauma team in the very young compared to the very elderly. It's way less. Even though, you know, they are representing more than 50% of severe trauma. So there's a massive deficit in our ability to recognize that a patient has suffered major trauma in the elderly. And that there's a lot of factors in this, and I'll come onto a table which kind of tries to pick out the key things. And again, the very elderly tend to get managed by much more junior doctors, and some of that will be you. I think 2%, 1.7 to 2% of all elderly trauma is sustained on a hospital ward. So you guys will be the ones looking after that. Now, this comes more to the structure of today's talk. Where do the elderly get injured? Well, it's by far predominantly the head. And then after that, the thorax, then the spine, then the pelvis and limbs. Very, very little in the way of significant abdominal trauma or anything else. And it is by far blunt trauma. There's very little burns, very little penetrating trauma. Although, I mean, we do see it, but very, very rarely. And so comparing that last slide to the injury pattern of those who actually died from their trauma, it's pretty much exactly the same. So the ages in question, purple, blue, and orange, here they all are clustered right at the top, where head is the predominant injury in those who died. Then the next most common injury is the thorax. And then it's in the age groups we're interested today, it dips right down again. Spine and pelvis are the next two. So heads and chests are by far the key groups. But, and this goes back to what I was saying about us failing to recognize severe trauma, they wait longer to be investigated in the emergency department. They will wait longer for their CTs, wait longer to be seen by a doctor. And that's because we didn't pick it up at triage. But does this mean that, well, it's okay because we much more rarely see the elderly die of their trauma in the emergency department? Well, it's still really significant. This is mortality rates. The dark green is at 30 days. And you can see there's a higher mortality in the elderly at 30 days. At 6 months, there's still a massively higher mortality rate. But here, I wonder if it's not so much the injuries they suffered there's of course an interaction. People who are becoming increasingly frail are, number one, more likely to fall and suffer trauma, but number two, more likely to be dying or close to their death. So I think falls in a lot of the elderly actually are a warning sign, that it's almost like a pre-palliative warning sign. The patients are becoming so frail they are close to the end of their life. And I think I heard today from a geriatrician that if you take patients who fall and lie on the floor for more than an hour, so that is somebody who's too frail to get themselves up from the floor, 50% of those patients will die within 6 months. But the majority is probably not actually a consequence of their trauma. The trauma was a consequence of the frailty that was leading to the end of their life in most cases. But at 30 days, I don't think that holds. At 30 days, patients are dying as a consequence of their trauma. So back to our vignette. You arrive on the ward and the nurses point at his room and then ignore you. And that, I'm afraid that's going to happen a lot. They call you, tell you how terribly worried they are about a patient and then disappear for the break, or go back to nursing the other end of the ward. So what do you do now, and how do you plan? How are you going to structure your assessment of this patient? Any takers?
I guess it depends how they are at the time, but I mean, I'm kind of way in between doing an A to E assessment or maybe just doing like a general assessment of systems. If you're talking about examining, that is, you mean. Okay, very good. I think the A to E is a great way to go when you don't know quite what's going on with the patient. And certainly, you know, in trauma, we have the primary survey, as it's called, is essentially an A to E assessment with a few modifications. So assessing it, I'd say A to E is the way to go, but with modifications we'll come on to. But before you go in the room, I would say, although it is the case that nurses do tend to go busy themselves with other tasks and think that's the doctor's job now, actually trauma is a team sport. You can't easily, well, you can't do a primary survey properly without at least one other pair of hands. And so you were going to have to go and get the nurse and say, I'm terribly sorry. You called me because you're concerned about this patient. I'm afraid I cannot assess them safely and properly without your assistance. So please, can you stop what you're doing and come and assist me now, please? And that's harder to do than it is for me to say you have to do it. But I think this is one of those times when, as an FY1, you have to go and assert yourself with the staff. And they will grumble and they'll make you feel pretty uncomfortable, but you do have to assert yourself and say, I need your help now. And if they say, oh, it's terribly difficult and I can't possibly because this is time critical medication, then I think the next thing you say is, then in that case, I'm going to ask you to stop what you're doing right now and go and call the hospital matron to come and get you some extra assistance because this trauma patient needs assessment. Do you know, so don't let them back you off, but do it politely and in a way that is supportive. But you can only do that if you know what's needed. So that's what's needed. You say, if you can't do this by yourself, then you need to call somebody right away to come and provide support. If you're in Addenbrooke's, of course, you do have the rapid response team. You could call the rapid response nurse, or in any other hospital, the ICU outreach nurse, and say, well, we've got this situation. We don't have enough pairs of hands and the nurse has got other time critical issues. So we need extra support straight away. Please, could you come? Okay. So ICU outreach, rapid response, hospital matron, these people are your friends, but don't go in there alone. Okay, and then in terms of A to E, so you know, you trained very, very well. It's drummed into you like it's a spinal reflex, airway, breathing, circulation, disability, exposure. So the A to E for trauma is slightly different because patients may be bleeding.
And you don't get a chance to put that blood back in if you allow it to bleed out. So the first thing we must do is assess them for really severe bleeding, and that's exsanguination. And that is no more than a quick eyeball around. It's not a careful, meticulous exposure and assessment. It's just looking for pools of blood, big stains of blood. Now, that's going to be extremely rare in the kind of trauma you're managing in this hospital room. The most common cause would be a scalp laceration that's being exacerbated by onboard anticoagulants. And if you find that, you just get some pressure on to stop it. And then the next thing is airway. Now, airway comes with cervical spine control, because another potentially rapidly fatal thing would be a spinal cord injury. Now, at this point, the patient doesn't seem to have one, but if we don't look after him right, we could inflict a catastrophic spinal cord injury that could cause him to die on the spot if it's high enough, or it could cause quadriplegia with respiratory failure if it's lower down, only slightly lower down. So we must protect that C-spine, and that is a life-saving intervention. Then it's airway, breathing, circulation. Now, the circulation side is a bit different, because you've got to go looking for focal sites of blood, which could be anywhere. It could be in the chest, it could be in the abdomen, it could be in the pelvis, it could be in the femurs, or it could be exsanguinating, but hopefully we'd have picked that up straight away. So it's a bit more in-depth, detailed examination of the whole body than it is if you're doing a medical A to E. And then in D, again, we're looking for sort of maybe more, there can be general signs of a brain injury, but there might be focal signs as well. So we've got to be a bit more detailed in our assessment of D. By the time we've done that, we have already exposed the patient. The only thing there is to make sure that they don't get cold. So that's the general structure of the C, AC, BCDE of trauma, and that's called the primary survey. We'll look at it in a bit more detail later on. But first, we've got to know a bit about what we're looking for. So what I'm going to start, the next section is about looking at the common patterns of injury, what there is for you to look at and look for. Okay, so when we're assessing just how sick this patient may be, like I said, the elderly are not just small adults. They behave quite differently, and we need to have that in our mind when we're assessing them. Otherwise, we can miss things or dismiss things too easily. And here's a table of it, and I'd hope that you can help me out by filling in some of these gaps. So the first thing is, when you walk in, you're just kind of eyeballing the patient. And as in the photograph, Jim looked all right, didn't he? But what differences are in the elderly that might cause us to underestimate the severity of the trauma that the patient has suffered, the severity of the insult to the patient? Any takers for cognitive differences? Somebody, is it Toby or Tony, I can't remember, already mentioned they may be delirious.
That wasn't that was someone
was
else.
It not? Sorry, apologies. They may be delirious, and that we've been told they're delirious, so we may go in, oh, he's behaving a bit oddly, that must be his delirium. We might be wrong about that. So don't dismiss delirium as being at their baseline. This might be a change following a head injury. But are there any other things you can think of?
They might have communication difficulties, voicing out their pain.
Absolutely right. I tend to think that they may have a dementia, and they're simply not able to communicate, or they're not even quite perceiving their pain in a normal way. Or it might also be, as many elderly are, tough as nails, brought up to think you shouldn't go to hospital. They may also want to believe, so that's one end of the spectrum. The other end of the spectrum, the cognitively intact independent patient, may not be willing to believe they've had a fall. And so they may be trying to dismiss these events because they don't want to accept the final proof that they're now old and frail. So they may minimize the injury that they suffered because they're pretending to themselves it's not a big deal. Anything else? Anything more physiologic? I think that's most of it. There is some evidence that they have altered, the elderly have altered pain thresholds because nociceptors don't, they're slightly less sensitive than they are in the young. So they simply perceive pain differently. I'm just going to move this out the way. So the point is that when you walk in, your patient may not be expressing as much pain as a young person would, given the extent of their injuries. And you may then be tricked into thinking, I don't need to worry about this as much. I'm not going to bother doing a full primary survey. Just quick check over will be fine. After all, we know the ROBs are all right. So don't be tricked. Okay, how about cardiac? Cardiac differences in the elderly that could cause you to miss or them to not show signs of serious trauma. Should we say cardiovascular? Well, we've already talked about beta blockade and hypertension, but there's also some evidence that intrinsically the elderly do not mount such a good quality sympathetic response. So even without the beta blocker, they may not be so tachycardic for the extent of their blood loss, for example. And also, they may be anemic, and they may have a lower capacity for blood loss before they run into severe problems. And they may have hearts with ischemic heart disease and reduced perfusion, so again have a lower tolerance for blood loss than a younger person. How about respiratory? Any thoughts on respiratory?
I guess they're more likely to have like COPD.
Correct.
I mean, it's quite known, but like their SATs might be lower. So, I mean, I don't know. That's a bit of a hazy one, I guess. But if I was to guess, then that could be something that could complicate things.
Yeah, you're absolutely right. The elderly do seem to tolerate lower oxygen saturations or live with lower oxygen saturations, even if they don't have any respiratory diagnoses. We tend to think they run just a little bit lower. And so you don't know if this individual patient is hypoxic because they've got COPD anyway, or if it's because they've just suffered a lung injury. So there's doubt in your mind. Whereas if you have the same patient, same injury who's young and they're hypoxic, immediately you know that's a chest injury, we need to investigate. But in the elderly, you've got that doubt. Is this? Let's just wait and see if there's a trend. So you're slower to act. Also, there are physiological differences that reduce their capacity to tolerate lung injury as well. Like, for example, they have poorer gas exchange. They do have underlying diseases, and kyphoscoliosis may reduce their chest wall expansion. So they're reserve. So they're at risk of deteriorating quicker in front of you. The rest are not quite so obvious as you eyeball the patient, but of course renal function is lower, so there is a lower reserve should they suffer a hypotensive hit, and also is a bit more care to think about whether or not we can give them contrast, whereas you just crack on without even worrying about it in a young person. But that delay, as you think about it, is a delay to diagnosis of severe injury. Skin and soft tissue, well, they do seem to split their heads more easily than young people, that's for sure. You can see horrendous scalp lacerations, big flaps that bleed very briskly, typically in the elderly. But the lean body mass, coupled with osteoporosis and osteopenia, increases their risk of fractures. They're also at more risk for hypothermia. Clotting, well, the iatrogenic one is the big headline, our anticoagulation. And comorbidities. So you see that little list of 5 diseases there: ischemic heart disease, diabetes, COPD, coagulopathy, and cirrhosis. A patient who has one of those diseases is 2 to 3 times more likely to die from their trauma than somebody who doesn't. So once you've got 2 or 3 or 4 going on, the rest of the mortality are really going up. Okay, looking at heads. Now this is going to be quicker than I intended because I realize I've kind of waffled a bit. So what do we have to worry about in heads? Well, the great thing about head injuries is that we've got a brilliant, focused set of guidelines that tells us when to investigate for a certain potential brain injury and when to not. So it does simplifies your thinking as long as you are aware of the guidance. You don't need to memorize it. You know, if you have a rapidly deteriorating patient, at the end of the day, you're going to put out 2222 call and get expert help. If they're not rapidly deteriorating, you've got time to go and look this up. All you need to know is that it exists. There's a couple of, obviously there's lots of patterns of injury for brain injury, but they converge on common problem of raised intracranial pressure. Now, I know you know your Monroe-Kelly doctrine. You know that the problem with raised intracranial pressure is the difficulty of getting arterial blood into that brain. And as the intracranial pressure rises, the arterial flow decreases. So, and it can happen because of bleeding into the brain, like the first 5 of those CTs. It doesn't really matter to you in the initial assessment where that bleeding may be. It's detecting the rising intracranial pressure that's the key thing. Aside from bleeding, you can have diffuse axonal injury where you get tearing of the fibers of neurons, and that causes brain swelling with the same ultimate pathway of raised intracranial pressure. So we just need to know those signs, and we also need to recognize them as early as we possibly can. So if you can know the criteria for CTing patients with a head injury, you'll arrange that much more quickly. And if you arrange it much more quickly, we may pick it up at a point where the collection of blood is smaller and before it's actually compressing a brain. And so you may save a life. So that's your key first pattern of brain injury. And there are some clear indications for a CT that nice guidance gives us. So the symptoms we're looking for is loss of memory for a period, an agitation or personality change, vomiting, a severe headache, a loss of consciousness for a period. If you've got any of those and their GCS is less than 13, do the CT straight away. And I would not worry about trying to correct for delirium, because you just, unless you know the patient personally very well, you don't know how severe their delirium is. Delirium fluctuates. Were they actually delirious right before it? You don't know. So just go by the GCS as given in the guidance and don't try and make adjustments. If their GCS is less than 15 at 2 hours after the head injury, then scan them. And then, of course, if there's any sort of signs that really concern you, like post-traumatic seizure, focal neurological deficit, or more than one episode of vomiting, that's an indication for the scan. And what do you do? Well, in that moment, you'll tell the nurses, don't give them any more anticoagulation. You need to discuss reversal with hematology. If the GCS is falling rapidly, then you can predict that we need to make a decision on whether to go for neurosurgical decompression or not. So get straight on the phone to your neurosurgeon. If they're more stable, you can get the scan and then call them afterwards. And if they're completely stable, I can predict that the neurosurgeons will simply say, if the GCS is completely normal, I can predict the neurosurgeon will say, okay, neurobes for 48 hours, rescan if they deteriorate. But if they're the same after 48 hours, then there's nothing we need to do. The second pattern of injury with head trauma is a skull fracture, and they can be depressed, like in the CT scan. They can be open, also like in the CT scan. I think if you look on the one on the right, you can see a little locule of gas on the inside that says it's most likely got a communicating pathway. Now, the depression may raise intracranial pressure. The open fracture leaves them at risk of meningitis. And then you can have a base of skull fracture. And here's the signs to look out for a base of skull fracture. So you've got panda eyes, you've got battle sign with bruising at the mastoid, and hematympanum. There's a few others as well to look out for, like CSF dripping from the nose or the ear, bleeding from the ear. And those fractures are generally undisplaced and don't need any neurosurgical treatment, but they leave the patient at risk for migration of respiratory pathogens into the brain. So we give them a vaccine against pneumococcus to prevent, or you do the best to prevent a meningitis. So suspicion of open or depressed skull fracture, or any of those signs that I discussed in the last slide, those patients get a CT scan, even if their GCS is normal, because we're looking for fracture patterns. Yeah, and so for those ones, you get the scan and you discuss with neurosurgery and you take advice. And I do that, right? There's pretty much no case where I've got an abnormality in CT and I don't discuss with neurosurgeons. We don't try to predict what they'll say and leave it at that. We always discuss every case, no matter how old, no matter how frail. So that's heads. Vaz, if you're still on the call, do you have anything that you want to add, then please do jump in at any time. Anybody got any questions about that?
I am on the call, just that I'm listening from the kitchen while I'm cooking.
Okay, very good. Okay.
No, it's great so far. Thank you. I'm learning a lot.
Okay, cheers. Any students got any questions or thoughts about that? Any experience with any of that? Okay, moving on to chest trauma then, which was the next highest common cause. Now remember, there are many more chest injuries that I'm going to discuss here. This is about the trauma that the elderly experience in the main, and the trauma that you're likely to have to look for and manage. Oh, drat, I've kind of given the game away here. So these are x-rays of the most common 2 patterns of injury in the elderly. So what's the top one?
Tension pneumothorax.
Yeah, thank you. And what makes a tension pneumothorax different from a simple pneumothorax? I
think you get the additional compromise of the cardiovascular, well, the cardiac system, essentially.
That's right.
Due to the, yeah.
That's right, exactly right. So as you can see, the pressure is pushing the mediastinum away from the site of injury to the extent that it's kinking the great vessels. And at that point, you get reduced blood flow, reduced cardiac output, and that's what puts the patient at risk. What is the temporary management of a tension pneumothorax?
Aspiration with a cannula.
Well, decompression, you're absolutely right. If it's truly tensioning, if it's under that much pressure, you don't need to go to the effort of sucking out air with a syringe. You just place the cannula with an open end and let air decompress out with a hiss. What's the definitive management of a tension pneumothorax? So we've got our needle in, we've temporized, but the chances are that cannula is going to kink. So it's not a long-term solution, and there's still a load of air in.
A chest drain?
A chest drain, absolutely right. So if we put the needle in and we decompress, do we need to proceed straight to the chest drain? The answer is no. We've temporized successfully. We've removed the risk to life. The patient may well be bleeding extensively from other parts of their body we've not seen yet. So we could be putting them at risk if we stop assessing them for the 10 minutes or so to place a chest drain. And that's 10 minutes if you're slick and you've got everything to hand. So no, we note the fact we need to put a chest drain in and we move on. Can anyone tell me what's in the lower X-ray there? What life threat are we seeing in there in the context of trauma?
Pneumothorax.
Yes, absolutely right. There's clearly a lot of fluid in there. In the context of trauma, that's almost certainly hemothorax. Now, what is the life threat there? So it's not the fact that the lung is getting squished. I've seen plenty of people with moderate pleural effusions, large pleural effusions, and they're doing just fine. The life threat here is how much blood, how much, a huge fraction of their circulating volume is being lost into the chest cavity. What would be, therefore, the temporary management of a massive hemorrhage into the chest? Well, it's resuscitation with blood products. We're going to know that this patient, we're going to see in our general examination, and then by moving on to our C examination, that this patient is going into hemorrhagic shock, having lost potentially 1.5 litres, 2 litres into their chest cavity. And that's the life threat. So the resuscitation for a massive hemothorax is a massive blood transfusion to replace that circulating volume. And the definitive management is to drain it, but not in the very acute phase. We're not draining it because it will turn into an empyema. We're draining it so we can find out if the bleeding has stopped in the chest or whether it continues to go. So we drain out everything that's in there, and then we see over the next 10 minutes, 30 minutes, an hour, 2 hours, 4 hours, whether or not bleeding continues. And if the bleeding continues, they're going to need cardiothoracic surgery to stop that bleeding, which may be coming from rib ends, may be coming from the intercostal bundle, it may be coming from a lacerated lung or a lung vessel injury. Does that make sense? So again, in the short phase, it's transfusion for the blood loss. In the long term, it's a drain to monitor losses and then refer for definitive management if it continues. Now, these two are the big two in the primary survey to identify, but they are not the most common causes of death. They're simply the most common things that we find in the elderly, and they're certainly not the most common causes of death. Can anybody think what the most common cause of death by trauma is in the elderly, in the chest? It's basically a simple rib fracture and the consequences of it. So where you have rib fractures, that energy that caused the rib to fracture has pushed the rib in then, and is literally, the ribs have then punched the lung. And that punch from the ribs to the lung causes a bruise to accumulate in the lung. That bruise can be really extensive. Because we call it a contusion rather than bruise. So a pulmonary contusion is the key thing that actually is cause of so much mortality in the elderly, combined with the pain of the rib fractures. Now, of course, in the elderly, the ribs are frail bones as well, and you can have multiple fractures. In a single line, still very severe. If you've got 2 lines of fractures in more than 2 ribs, then you have a detached segment called a flail segment. And of course, that's highly mobile and inflicts a bigger injury to the underlying lung. The pain of rib fractures is quite bad at the time of the injury, but on day 2, day 3, the pain increases a lot. I don't really know why, but it does. Vaz, I think you've got unmuted. Would you mind muting again? and so the pain worsens over the coming days. That causes the patient to be unable to expand their chest. Believe me, I've had rib fractures. 2-3 days down the line, it hurts so much. It is so difficult to expand your chest properly. It hurts like crazy. And then underneath that, you've got all this blood, which is a perfect culture medium for a pneumonia, and is also potentially such a big volume, it really causes respiratory embarrassment. That combined contusion and rib fractures is the most common cause of mortality in terms of chest wall injury, and the mortality in the elderly can be 22%, I believe. There is the problem too, of course, that in a young person, you would just, if you recognize respiratory failure because of all this, you'd simply intubate and ventilate. But unfortunately, in the very elderly, intubation and ventilation by itself may be a death sentence, because weaning off a ventilator in somebody with weak chest muscles may become impossible. So this is where we are caught, and this is the problem. This is why it's so commonly fatal. But there is a system to prevent death, and Microsoft has completely ruined my slides in changing it from Google to Microsoft. Okay, and so there's a risk scoring system whereby you take account of the frailty or the age of the patient, you take account of whether the fractures are one-sided or two-sided, and how many fractures they've got. There is a scoring system, which I won't bore you with here. Just, if you know that it exists, you'll know to go look for it. And based on that score, you can decide what interventions to go to. And if you look at it, it really ramps up into very aggressive management. So a risk score of 7 to 10, which in a 70-year-old might only be a couple of rib fractures, you're already considering a PCA for them, rather than just intermittent morphine, which you would probably instinctively go for. And that's a relatively low risk score, isn't it? At a score of 11 to 15, you're looking at calling an anaesthetist to arrange regional anesthesia, so that's intercostal nerve blocks, or lignocaine patches and PCA. And then a score of over 15, which is surprisingly easy to get to, a thoracic epidural. And then there is another option, which isn't listed here, of going to a cardiothoracic center for rib fixation. So actually, our trusts would like us to manage this very aggressively, much more aggressively than you instinctively would, just by it's just a rib fracture or a few rib fractures. So bear that in mind. We treat it much more aggressively than you would expect, because the mortality is so high. Okay, any thoughts, questions about that? Okay, there we are. Right, spinal trauma. Again, we have excellent, nice guidance for this. If you remember back to that graph, so heads was 80%, chest was 25%, spinal trauma is much lower. I think it was, if I recall, it was about 10%. But we've got to manage it right. That's 10%, given that we manage it right, and it can be. We're risking a death if we miss an unstable spinal fracture. So this is really important too. So it kind of splits into cervical, because the neck is mobile and vulnerable to particular injuries, and then thoracolumbar. There's loads and loads of potential injury patterns. Can't go through them all. But what I wanted you to take away from this slide was simply that every one of these has got a fracture on it. And some of them are obvious, like this posterior listhesis. Some of them are a bit subtle, like this odontoid peg fracture. But some of them are so subtle, you'd even miss it if you were looking for it some of the times. And that gap there is indicative that the C1 ring has been burst. And I think a lot of people would miss that. So the key point is to be aware that if you are getting x-rays on a patient, don't try to interpret them yourself. You need a radiologist or a trauma-trained registrar or consultant to look at them. So fractures can happen from innocuous falls. I looked after a patient in ICU who got a fractured C-spine from rolling out of a hospital bed and landing on a hard floor. Fall from standing is the most common cause, but I'm aware of a case where a patient sustained a C-spine fracture after falling into a snowbank, and it was an unstable, life-threatening C-spine fracture. So the symptoms, they might have tenderness at the midline at the back, but if you've got anterior vertebral body fractures, you might not be able to elicit tenderness that way. So if the patient is complaining of throat discomfort or airway compromise, that might indicate, that might be the only symptom you get that there is actually a C-spine fracture. The patient might be holding their head or holding it in a different, it may be angulated in a different way. Please don't try to align that head to normal. Keep them in that position. Any cord injury might manifest as a sensory level anywhere, or upper or lower limb neurological abnormality or priapism. There is guidance in that document about when to investigate for a C-spine fracture. But it's easy to remember. Immobilize the patient, and then you've got as much time as you like to actually go and look up the guidance again to remind yourself. But put simply, because we're dealing with the elderly, the over 65s, if they've suffered trauma, a fall from standing is good enough, and they either complain of neck pain, or you can't figure out if they've got neck pain because they're cognitively impaired, either acutely or chronically, or they have a distracting injury, like a femur fracture or something that's causing them to be into like, that's so much sore, so much in pain that you can't get them to really reliably attend to a neck examination. Or if they have any neurological abnormality, even in the absence of pain, immobilize that patient and arrange imaging. Now, there's guidance about when to do plain films and when to do CTs. And it boils down to this. If they've got no other injuries and you don't have any signs of a C-spine fracture, like neurology, then do an X-ray. If you have signs of cord injury, like neurology, motor neurology, paresthesia, priapism, or if they've got other injuries that also indicate a CT, then do a CT of the neck, okay? So if it's unlikely and there's no other injuries, X-ray. If there are other injuries or there are signs of neurological injury, go straight to CT. Now, Saza is asking a question, is it usually impact-based trauma that leads to C-spine fracture, or can things like whiplash be accompanied by a fracture? So with whiplash, you mean a deceleration injury. So this would be like, so the patient's chest stopped moving and the head carried on forward and then flipped back when it got to the extent. So yes, absolutely, that can cause a fracture. In fact, if we go back up, I think the middle one at the bottom is a teardrop fracture. Can you see that? So that little flake there, that's all that's wrong on that X-ray. But that little flake there in that configuration tells you that there's complete disruption of the anterior ligament and the posterior ligament. And also that at the time of injury, probably the upper vertebral body moved backwards into the spinal cord and then came back again and could do it again at any time. So that is classically a whiplash injury that causes that kind of fracture and can absolutely be associated with quadriplegia. So let me get back on. Or am I now? Yeah, so that's the guidance for considering a cervical spine fracture. Tony asks, slightly unrelated question, how do you do a proper ET assessment if someone had a motorbike and was unconscious, as in if on the street? Well, we'll come to that much later on. Tony, can you remind me of the question later on, please? And we'll go through it then. Indications for imaging. Yeah, okay, so we've done that. There's a couple of other ones. So there's all that suspicion of C-spine injury. But in addition to that, if their GCS is less than 13 on arrival, remember you're scanning their head for that. So scan their neck as well, because what we don't want is a piecemeal backwards and forwards to scan as we assess one bit and then later on discover that there's concerns in another bit. So if they're going to scan, they go to scan once. And really, if they're going to scan, just scan them from head to pelvis, because that's the best care for the patient. An intubated patient needs to be scanned because they're almost certainly going to surgery or ICU. They're log rolling the patient. They need to know if there's an unstable fracture. If indeed you don't even think that there's a C-spine fracture, but it's not ruled out, but they need to go for an anesthetic for any other trauma, well, that patient, if they're getting anesthetic, the anesthetist would like to know if they can extend the head to intubate them, or whether they have to intubate them with inline precautions. So including the neck on the scan that they're inevitably getting for whatever the surgery's for helps the anesthetist enormously. And then lastly, if there's an inadequate or suspicious plain film, if you actually do the x-ray and there's a fracture on it, do the scan. If the x-ray didn't completely include the C-spine, do a scan. And that's another part of getting a specialist to interpret it, because it's not as straightforward as you think to decide whether or not you've got an adequate film. But let's jump out of our vignette and think about a patient that's sitting up in bed reading a book. And the nurses have said, this patient is complaining of neck pain after a fall. Can you go and decide whether or not we need to scan them? So if the patient is comfortable sitting, or they've walked since the injury, or they have no midline C-spine, if they have no midline C-spine pain, or the pain actually wasn't there straight after the trauma, but progressively came on later. They don't need to have all of these factors. If they have any one of these factors, then you can move on to try and rule it out clinically at the bedside. And then you do a quick assessment of the clinical condition of the patient. Are they GCS-15? Are they safe to assess? They've got no narcotics on board altering their behavior. They've got no distracting injuries. And that is an injury that causes distress to the patient. It may be a massive injury like a femur fracture, or it might be a patient that's just really stressing them out, like my hand is a different shape. If they can't pay attention to your assessment of the neck, then they're not assessable. And of course, if they've got no neurological abnormalities. So what you do is you go up to them, you say, how are you? You seem to be comfortable, and you meet one of these criteria in the first box. You establish that they're accessible, and then you check for motor or sensory level in the neck, all the way down the arms, and then motor function of the neck, of the arms, sorry. And then if after that you're still safe to proceed, you've got no neurology, then simply ask the patient to rotate their neck 45 degrees to each side. If they can do that, there is no fracture. And that's what we do in the emergency department every day. Also, have them touch their chin to the chest and gradually, carefully look up. And if they can do these things, even if they say, oh, doctor, that's a bit uncomfortable, no problem. If you've got a fracture, you can't move your neck. Just like if somebody's got a fracture of their arm, they protect it, they don't move it. And if you try to move it, they yelp and they don't let you. It's the same with a fracture in the neck. If they can't move their neck, however, you have to immobilize them and investigate them. Does that make sense? So that is clearing the C-spine. It's in the guidance that I showed you, the spinal trauma guidance. And it's basic, and it's called the Canadian C-spine rules. And this is really worth knowing. I think this might be core material for finals, actually. If they've got one low risk factor, then clinically they're safe to examine. If they can rotate their neck, then they don't have a fracture. If you can't rule out a C-spine fracture, then immobilize, initially by a staff member doing it, and then apply standard spinal precautions. Give them painkillers and antiemetics, because this is horrible. And obviously they have pain somewhere from their trauma. That pain can cause patients to vomit. The morphine to control the pain can cause the patient to vomit. So if you strap them down, you've got to do it safely, or they'll aspirate and potentially die, which is not what you want. So in that vein, can anybody on the call spot anything wrong with that picture? It was the only one online I could grab last night when I did these slides. But there's a lot wrong with that picture. Can anyone spot it? Okay, it's fair enough. This is a difficult question. The first one is that this patient is wearing a C-spine collar. And as a rule, we are moving away from using C-spine collars. And it's been years and years since I put one on a patient. Would I put one on if somebody was unconscious? Tricky one. Quite possibly not, actually, as long as I can be satisfied that their head is going to remain immobile. The problem with a collar is the evidence is that, number one, they don't stabilize the C-spine. There's so much play in them, or there's enough play in them, that actually the neck is moving sufficiently that the cord could be injured. So it doesn't do a very good job. Secondly, that C-spine collar, because it's so tight on, the way we're trained to apply it, it can actually cause distraction at a fracture site, and therefore theoretically exacerbate spinal cord injury. So we don't like collars anymore. However, there's no clear decision being made about whether to apply collars or not. I mean, firstly, you've got to be trained in how to put them on. So you have to decide if you can do that. In the meantime, you can immobilize quite fine, just applying inline stabilization with it by a staff member. But even if you can, so it's a nuanced decision. Involve your trauma specialists. If you've got this far, I mean, you'd want somebody like an orthopedic registrar or a general surgeon to be assessing the patient. So get their opinion on the local trust policies. The second key thing that I don't like about this picture that's very, very dangerous is that this patient has been immobilized from the neck up, but not from the neck down. So if you take a look, these straps going across are clearly taped onto the patient's trolley. And that means that patient's head is strapped in place and it's strapped down to the trolley he's on. But his body has not. If he'd been immobilized properly, there should be a orange strap or any strap at the level of that seam on his scrubs. The fact it's not there, well, what does that mean? If he gets nauseated, if he thinks he's going to vomit, what's he going to do? He's going to do this. He's going to try and roll over. His head's going to be stuck, but his shoulders are going to move. And he's literally going to pull apart his fracture site and potentially injure the spinal cord. So that's an exceedingly dangerous situation. Even if, so what you need to protect your patient is for them to be on a trauma board. And then on the trauma board, you put the blocks and the patient, and then you strap the patient's head and the rest of their body to the trauma board. And so if they want to vomit, all you have to do as a team is lift the trauma board to 90 degrees. The patient will remain in the correct line on the board and they can vomit and protect their airway safely. This picture terrifies me. It's awful. And he looks like he's blissfully unaware. Now, you're probably thinking, well, how on earth do I do that? I'm an FY1 in the middle of the night in a urology ward. How are you even going to, am I going to meet the expectations you're putting on me? Well, it's very simple. The patient is lying on a bed. So right now he's safe. You get a staff member to provide inline stabilization with their hands like in the first picture, and now they're completely safe. In order to get them onto a trauma board, you are going to need help. You're going to need lots of pairs of hands, and you need a second bed. So you call for a porter to bring a second bed, you bring it alongside, and you need to call the emergency department and ask your friendly emergency registrar, please, can we have one of your trauma boards for a trauma case on the ward? And you put the trauma board on top of that second bed, and you use a pat slide, the big plastic sliding boards that we use, and lots of pairs of hands to slide the patient across onto your trauma board, keeping them nicely aligned all the way through. And now, ta-da, your patient is on top of the trauma board very safely. Tony's asking, would that be a 222 situation? If the patient is GCS 15 and is hemodynamically well perfused, respiratory normal, you've not identified any other problems, Probably not. It's more of a call to the hospital matron to say we need lots of pairs of hands on ward, whatever. And so then your patient is on the trauma board and you can strap them on, apply the blocks and tape that you can see there, but that tied onto the trauma board, then wheel out that second bed. And there you go, your patient is nicely packaged and now you can be taken to radiology quite safely. Okay, on there, okay, so we've talked all that through, and then at the bottom picture there, there's a picture of a patient who's been reasonably well immobilized and he's been tilted to 90 degrees. So that's what we're aiming for. Bizarre, I have no idea where this picture was taken. I nicked off the internet and it looks like he's been wrapped in cling film, which is odd. I don't know why they would do that. But do notice on that picture, he's not perfectly immobilized. Can you see how his middle is sagging down a bit? So this is not a perfect system. So don't just willy-nilly move patients around, because in that movement, there's probably more than the tolerance of an unstable, of a thoracic or lumbar fracture. That's a video I never got around to sorting out, apologies. So that's C-spine fractures or concern for a C-spine fracture. Thoracic and lumbar spinal trauma is pretty much the same. They've got a patient who's had a fall and they're complaining of back pain or pain on coughing, or they've got a neurological abnormality. And remember, T1 supplies the ulnar nerve, so it could be an upper limb neurological abnormality. Or they've got a sensory level and you need to sort of feel down looking for a sensory level, or they've got priapism. And there you'd be concerned for a lower down spinal cord injury. The steps you take if you are concerned is pretty much the same. Get them on the spinal board. If you can still, if the patient is accessible, clear the C-spine, but get them on the same trauma board to immobilize them in order to investigate a thoracic or lumbar spinal fracture. And again, the guidance is on that same document, and it is long, extensive, but put simply, if you've got an elderly patient who suffered trauma, they're complaining of back pain, or you can't assess them, or they've got neurology, then immobilize and investigate. Immobilize first, ask questions later, using the same methods that I already talked about. And again, so let's again jump out of our vignette and think about the patient who's lying there on the bed, who's completely well. You've done your primary survey and they have no injuries that you can identify. They're neurologically normal in GCS 15 and they're saying, but doc, I've got this pain in my back. What are you going to do about that? Well, you're perfectly reasonable to say you have pain. I don't want to log roll you because that can move a fracture. And so therefore, we're just going to immobilize you and send you for imaging, which would be an X-ray if there's nothing else wrong with the patient, or a CT if there are things wrong with the patient. If, however, there literally is nothing wrong, the patient's going, well, I'm a bit uncomfortable, but I'm not really bothered. This seems all right, doc. So you just want to rule it out. You've not ruled in the fracture. You're at the point where you'd like to completely explicitly rule it out. Then what you can do in that context is think about log rolling the patient. What you need is a large team, 1 to hold the head, 3 to roll the patient to the side. Patient holding the team member holding the head is in charge of the movement, and they call the shots. And they would say, when everybody's ready, ready, steady, roll, and everyone rolls at the same time to keep the patient in line. Your job then, as the assessor, would be to first to palpate down the spine, and you're looking again for a spinous process or posterior vertebral body tenderness that would indicate a fracture. If you find a focal tenderness, you're done. Put the patient back and investigate. If there's no tenderness to palpation, then the next thing to do is to percuss, literally thump, not crazy, but good and firmly thump down the patient's spine. And what that will do is cause vibration that would help you detect any fracture in the anterior portion of the vertebral body. Again, any focal tenderness on percussion, you're done, roll them back and investigate. If there's no pain to percussion or palpation, then invite the patient to sit up. And if they can do it without pain, you're done, you've ruled it out. And again, like the C-spine, if you send them for x-rays, don't try to interpret it yourself. The signs of a fracture are subtle. You need somebody specialist to do it. Keep them immobilized, and if you find an abnormality in any of this, you talk to your local spinal specialist. And in Edinburgh, that's neurosurgery, but often it's orthopedics, particularly if you're in a trauma unit or a district general hospital, it's orthopedics. Okay, any questions about that? A key thing to note, though, is, okay, fair enough. I'll just get onto the pelvic and hip, and I think that's the last one, really. How about that, Baz? Another 5 minutes?
Yeah, absolutely. Yeah.
Perfect. So pelvises. So now the log roll, I really must emphasize, only gets done if you're not concerned about any other injury, really. The pelvis is challenging and a really important thing to look at in trauma. The particular problem with the pelvis is that it can fracture in many ways, and those fracture sites are large and can bleed a lot. You can lose a lot of blood into the pelvic cavity, potentially a third of your circulating volume to 2/5 of your circulating volume. There's no way to prevent the bleeding itself with compression. So we need to look at the pelvis to look for signs of injury that may indicate bleeding. The particular challenge is that if we move the pelvis and disrupt a clot that's formed from any bleeding site, they may not be able to form a new clot because the fracture sites can be so large that they consume virtually all the patient's clotting factors to stabilize that bleeding. If you disrupt it, it may never reform and they may bleed progressively to death. Here's a picture of some patterns of pelvic injury. The first one you can see is a disrupted pubic symphysis. In that case, the pelvis has been flattened and opened out. We call it an open book fracture. And the sign there is that as the pelvis is opened out, so too are the acetabulums, and that will mean that the feet are kind of flopped out like that. The next one is such a poor quality x-ray. I can't remember what the injury. Oh yes, so it's a lateral compression fracture. Now here, one side of the pelvis has been folded in. That's not so severe because it reduces the capacity of the pelvis to hold blood, and so it tends to tamponade a little better. But again, you'd see it in rotate feet or knee or leg sort of misplacement. The third one is a vertical shear where the pelvis has been broken up. You would see abnormal shortening of one of the legs. And then the last one is a simple pubic ramus fracture, and we see these and dismiss them and send them off to medicine all the time because orthopedic surgeons don't want to fix them. However, a patient who's I have seen a patient who's anticoagulated and was too frail for surgery bleed to death from one of these. And we identified it and we palliated because it just wouldn't stop bleeding. So it can be a very serious injury. So we can't move the pelvis. So we have to look for external signs. We mustn't press on the pelvis in any way that may deform it. So what can we do? If there is a suspected fracture, then immobilize it with a pelvic binder. Now, they don't work in all cases. Vertical shear, they can be as harmful as they can be good. But in an open book fracture, what they can do is return the pelvis to its normal shape and reduce the volume that the bleeding can go into. Another thing is that it's a big warning sign. We're concerned about this pelvis and leave it alone. And then if you're concerned about a pelvic fracture, you must get imaging and you must not log roll that patient because log rolling it could disrupt them. So if we applied the pelvic binder, and I realized there's not a picture of one on the slide, I'm sorry, but if we find ongoing bleeding from a pelvic fracture, then that's going to need either general surgeon to open and pack the pelvis, or embolization with interventional radiology. And that's what you see in the bottom there. Can you see in this contrast CT, there's a blush there, that little line that's indicating active bleeding from a vessel in the pelvis. And here are the pictures of the bleeding site and then after embolization. Oh, excuse me, my screen has just done something funny. Can everyone still see my screen? Now I've kind of switched off onto a sort of editor, but that's because my screen went funny. Femoral fracture, they simply need stabilization to prevent further bleeding. Now you diagnose them by a deformed thigh. You see how spiky that fragment is there. Well, on the right-hand picture, you see an open femoral fracture. And on the left, you see an open femoral fracture, that tiny little spike there. And obviously that's not something to worry about for the primary surgery, but that's going to need orthopedic intervention. The bleeding from a femur in isolation doesn't cause too much bleeding, about 1/6 of your circulating volume, but taken with a bit of pelvic bleeding and a bit of chest bleeding and a scalp laceration, this can all add up to a life-threatening hemorrhage. And that's how you stabilize it with a glorified tent pole called a Kendrick traction device and some struts around the leg, and then you x-ray. Abdominal trauma is very complex, but also very simple. If they've got any signs of abdominal pain, injury, bruising, then your options are either observe their serial vital signs or just go and scan to look for internal bleeding. So for you, the decision is very easy. If any of these patients are bleeding, if becoming hypotensive, the rule we follow is hypotension is hypovolemia until proven otherwise. Quote unquote, brackets, except for the tension pneumothorax. So if you've ruled out a tension pneumothorax or decompressed the tension pneumothorax and the patient is hypotensive, they are bleeding. And if they're bleeding, they need a CT scan from the head to the pelvis. Now, this is where I would go on to putting it all together and actually teaching a primary surgery, but Vaz is quite right. We've got to 7:30 and I think it's time to stop. So I'll try and schedule a part 2 to this talk, and hopefully it'll be quite a bit shorter. And we'll actually go through how a primary survey is still an ABCDE assessment, but how it's quite drastically modified to look for trauma. So I think we'll wind it up there. Does anybody have any questions they'd like to ask?
The motorbike thing, I think I mentioned.
Yeah, I think we'll have to leave that for part 2.
Yeah, that's fine. Yeah, I'm happy with that. But that's fine.
Yeah. Any other questions? So I think, so to summarize what we've talked about today, we've talked about how the elderly are extremely good at hiding serious injury, that they're vulnerable to serious injury from apparently innocuous trauma, and that they do go on to die from it. And you may be the sole provider attending to them in the middle of the night. So I just want you to understand how serious it can be. Don't underestimate it and get help. Okay, we'll stop it there. Hi, Vaz, you switched back on. Is there anything you want to add?
No, nothing to add. Thank you very much. I learned a lot. So I hope
I'm not sure that's true, Vaz.
We'll see everyone next week, Wednesday, and that will be at between 6 and 7. That's the aim. So we will see you next week, and it's Joe Selve, one of our registrars, who's going to present. I don't know the topic yet. She hasn't told me. So as soon as I know the topic, we'll email it out. We'll also email the link out of this recording, so you can watch it as well if you want to, or pass it on to your friends. Thank you very much.
Thanks for attending.
Ian, you're right?
Yeah, very good. How are you?
I'm going to stop, I think.